Good day, I am Associate Professor Byung-Soo Ghang at Jeju National University College of Medicine. I have recently been developing a clinical decision support system designed to assist doctors in clinical settings through both a program and a mobile application. The topic I wish to address today pertains to the relationship between gout and cardiovascular diseases. I have conducted a total of 4 studies on this subject, and I will elaborate on one of these studies. As I will mention later, my argument is straightforward. The phenomenon of a gout attack in the joints can also occur in blood vessels, and, as a result, a portion of acute coronary syndrome and stroke cases could be attributed to this phenomenon. The reason I am sharing this content on YouTube is to provide an in-depth introduction to the concept of a cardiovascular gout attack, a theory I first proposed. Although it has been published in a paper, it is not yet widely known, and there are details that could not be included in the publication. While presenting my findings at conferences and in scholarly papers is subject to certain limitations in length and time, YouTube offers a platform without such constraints, allowing for a thorough explanation. Gout is an exceedingly common condition. Globally, there is a rapid increase in the incidence of this disease, largely attributed to changes in dietary and lifestyle habits. Furthermore, the trend of its prevalence among younger patients is sharply rising. As you may be aware, gout is a metabolic byproduct of the breakdown of purines, which are components of DNA. What is critical to understand is that obesity has a greater influence on increased uric acid levels than diet alone. Although diet related to gout is often emphasized, I believe that weight control and exercise are more significant. A considerable number of those with gout also have accompanying metabolic syndrome, including diabetes and hypertension, which underscores the importance of weight reduction. Additionally, I strongly advocate for healthy lifestyle habits, particularly abstaining from smoking. Of course, alcohol consumption is not advisable. Not only does alcohol raise serum urate levels, but it also tends to lead to increased food intake. However, I posit that exercise and smoking cessation are even more crucial than diet. Educating on what is commonly understood as healthy lifestyle practices is of paramount. In cases of obesity or diet leading to increased purine metabolism, there is a consequent rise in uric acid levels. This can also occur due to diminished renal function, which hampers the excretion of uric acid, thus elevating its concentration. When uric acid levels exceed 6 mg per deciliter, monosodium urate (MSU) crystals begin to form. Several factors, including temperature and acidity, can influence the crystallization process of MSU. It is understood that optimal conditions for such crystallization often occur in the feet. Although specific thresholds may vary, it is commonly stated that reducing serum uric acid below 6 mg per deciliter can dissolve MSU crystals. This is akin to the principle where increasing the concentration of salt water leads to salt crystallization, and diluting it with water causes the crystals to dissolve. However, these MSU crystals are not simply exposed within our body. Typically, various cells and tissues encompass MSU crystals, and this encapsulating structure is defined as a tophus. I perceive this as similar to how a capsule shields the medication inside. Macrophages and giant cells surround the periphery, safeguarding it. My hypothesis is that the body encases the inflammation-inducing MSU crystals with a persistent inflammatory response involving macrophages and giant cells, among other inflammatory cells and byproducts. This containment likely prevents MSU crystals from triggering severe inflammatory episodes like gout attacks. The extent of encapsulation may dictate the degree of chronic inflammation, which I understand to be a determinant in the progression of the condition. However, these MSU crystals are not merely dormant within the body. In case to prevent severe inflammation, they can become unshielded under specific conditions such as a rapid change in urate levels or due to trauma. When freeform MSU crystals are exposed, the intense inflammation known as a gout attack is triggered. Starting urate-lowering therapy, ULT, especially at a high dose without a gradual increase from a low dose, can lead to a swift decrease in uric acid. This abrupt change may cause freeform MSU crystals to detach from pre-existing TOFI. Furthermore, rapid onset hyperuricemia due to triggers like alcohol consumption can lead to the formation of freeform MSU crystals. It is these newly formed freeform MSU crystals that cause the rapid inflammatory response leading to a gout attack. In this context, the process by which freeform MSU crystals dislodge from TOFI is known as crystal shedding. These crystals, through various mechanisms, can amplify the inflammatory response, leading to severe inflammation. Thus, an individual may maintain asymptomatic hyperuricemia until one day, freeform MSU crystals shed from TOFI, or a gout attack is precipitated directly by hyperuricemia. Following an attack, the individual may return to a symptom-free state. During this period, although TOFI are present, the surrounding inflammatory cells and the fibrovascular zone created by inflammation protect against gout attacks by encapsulating the freeform MSU crystals. Over time, as hyperuricemia accumulates and the frequency of exposure to freeform MSU crystals increases, the occurrence of gout attacks gradually rises. Eventually, if TOFI grow too large, the severity of chronic inflammation intensifies. As the exposure to freeform MSU crystals becomes more frequent, the condition progresses to a chronic inflammatory arthritis type of chronic gout. TOFI also causes persistent chronic inflammation, causing surrounding bone erosion. Damage to joints occurs. As a result, when gout becomes severe, even deformation of the joints is observed. Let's now consider the relationship between gout and cardiovascular disease. My hypothesis is straightforward: if TOFI or MSU crystals are present within the vascular system and incite the same severe inflammatory events as they do in joints, then they could trigger acute coronary syndrome or stroke. The implication here is profound. Gout is not merely associated with cardiovascular diseases incidentally, but could be a direct causative factor in their development. It is widely acknowledged that higher levels of uric acid are associated with an increased frequency of cardiovascular disease. For those interested in exploring the vast body of research on this topic, a simple search on Google will yield extensive studies. The diagnostic utility of dual-energy CT, DECT, in gout is well established. In this study, DECT imaging revealed signals consistent with MSU crystals in the thoracic aorta. To address the possibility of a false positive, a bladder stone that had been passed was also imaged using DECT, which detected signals indicative of MSU crystals. Further analysis confirmed the presence of MSU crystals. Remarkably, this study found that 88% of gout patients showed vascular MSU crystal signals on DECT imaging. In a subsequent study, vascular MSU crystal signals were observed in 86% of gout patients using DECT. Intriguingly, this research was conducted using cadavers. Tissue examination at the sites where DECT detected MSU crystal signals confirmed the presence of MSU crystals under microscopic analysis. Moreover, MSU crystals were observed in 6 out of 55 hearts that were removed for transplantation. Notably, 38% of these patients had gout. Additionally, MSU crystals were not only found in the vasculature but also in various other tissues. Such findings demonstrate that MSU crystals are present in extraarticular tissues. Particularly, the majority of gout patients showed vascular MSU crystal signals on DECT imaging. This confirms that MSU crystals do indeed exist outside of the joints. So the question arises, do these extraarticular MSU crystals sit idly in the body without having any effect? There is a fascinating study to consider. Patients with asymptomatic hyperuricemia who showed no TOFI on ultrasound had rates of moderate to severe coronary artery calcification similar to those with non-uricemia. However, the presence of both asymptomatic hyperuricemia and TOFI as detected by ultrasound was significantly associated with moderate to severe coronary artery calcification in multivariate analysis. I interpret these findings to suggest that the presence of tophi in joints indicates a potential for tophi in other tissues, particularly the vasculature. It is my hypothesis that the chronic inflammation caused by these tophi may contribute to coronary artery calcification. This summarizes my hypothesis. When MSU crystals in joints precipitate an acute inflammatory response, we see a gout attack. When these crystals form tophi and cause chronic inflammation, it leads to chronic gout. Furthermore, if MSU crystals are present in the cardiovascular system and trigger a gout attack, this can potentially result in acute coronary syndrome. I have defined this phenomenon as a CV gout attack. The persistent presence of low-grade chronic inflammation could initiate or exacerbate arteriosclerosis. This concept may also extend to the kidneys. This material is currently under submission to a journal, and upon publication, I will produce and upload a video related to this data. To recapitulate, my hypothesis posits that MSU crystals can be a causative agent of cardiovascular disease, and some cardiovascular events may, in fact, be what I term CV gout attacks. Additionally, the rapid fluctuations in uric acid levels, which are a known factor in triggering gout attacks, may lead to the formation of free-form MSU crystals and ultimately cause cardiovascular events. This paper discusses the renowned CARES trial, a study designed to determine the incidence of cardiovascular events following the administration of Febuxostat compared to Allopurinol and to assess whether Febuxostat posed greater risk. The trial's outcomes indicated a higher cardiovascular mortality in the Febuxostat group, influencing FDA recommendations and the ACR gout guidelines. I had anticipated results similar to the FAST trial for the CARES trial based on the hypothesis I'd been considering even before the CARES trial was publicized. Although not statistically significant, I hypothesized that due to Febuxostat's stronger urate-lowering efficacy compared to allopurinol, it would result in a greater reduction of MSU crystals, potentially leading to fewer CV events. This was indeed observed in the FAST trial. Now, if you look at the Kaplan-Meier curve for the primary endpoint of major adverse cardiac events, MACE, you'll notice that for the first 2 years, as I predicted, Febuxostat showed a lower risk of CV events. However, around the 2-year mark, there's an inflection point, after which the curve for Febuxostat is slightly above that of allopurinol. While the difference is subtle, some might consider it negligible. Interestingly, upon further scrutiny, this study had more than half of its participants discontinue prematurely, with the median duration of exposure being approximately 2 years for both Febuxostat and allopurinol, aligning with the inflection point I mentioned in the Febuxostat curve. After the publication of the CARES trial, follow-up studies in the United States have shown a pattern similar to what was originally observed. At around the 2-year mark, there is a subtle yet sudden increase in the Kaplan-Meier curve for Febuxostat, indicated by the red arrow, reminiscent of the CARES trial's findings. I considered whether this trend could be attributed to the discontinuation of medication, and whether it might be a characteristic unique to gout patients. Gout is a condition that can be nearly cured if urate-lowering therapy is consistently administered. Such powerful treatment typically leads to a significant reduction in the frequency of gout attacks after 1 to 2 years in many patients. Consequently, as these studies indicate, a considerable number of patients discontinue urate-lowering therapy after 2 to 3 years. This cessation could potentially be the cause of the phenomena observed in the Kaplan-Meier curves previously discussed. Thus, in the CARES trial, more than half of the participants discontinued the study, and half of those did so voluntarily or were lost to follow-up. I believe that this characteristic of the CARES trial accurately reflects the general medication adherence patterns of gout patients. Based on my hypothesis, I entertained the following scenario: patients voluntarily stopped their urate-lowering therapy, ULT, after 2 to 3 years as their gout attacks diminished. This led to rebound hyperuricemia, rapidly forming free-form MSU crystals within the vasculature. I speculate that, similar to a gout attack, this significant vascular inflammation caused by MSU crystals could precipitate acute coronary syndromes, a phenomenon I've termed CV gout attack. The higher mortality observed in the Febuxostat group during the CARES trial, as indicated in the supplementary tables, could be due to the patients in the Febuxostat group maintaining lower uric acid levels. In other words, the Febuxostat group may have experienced more severe and profound rebound hyperuricemia, resulting in more frequent CV gout attacks and, consequently, an increased number of deaths. I sought to verify this speculation. The CARES trial supplementary materials providentially included mortality data based on treatment status. Based on the treatment status information provided, I was able to infer mortality during different phases of the trial. I reconstructed the data to distinguish between mortality during the entire period with and without the drug treatment, mortality while on medication, and mortality after discontinuation of the drug. This records the number of deaths and the daily incidence rate of mortality by treatment status. It was observed that mortality increased by more than 30 times after discontinuation of the drug compared to while the drug was being taken. These findings have been published in Rheumatology. At the time, however, I did not have access to the raw data of the CARES trial, making it difficult to determine whether these patients died from other diseases or worsening conditions. Therefore, I could not rule out the sicker stopper effect, the possibility that those who were sicker stopped the medication, leading to their deaths. The letter concluded with a call for further analysis. Based on this hypothesis, I reanalyzed the raw data from the CARES trial. The paper has been published in RMD Open and is available for anyone to download. Given the extensive nature of the tables in the publication, downloading and reviewing the material may be advantageous. Let's take a look at the methodology and outcomes of this research. As previously mentioned, if CV gout attacks truly exist, otherwise they would share the same pathogenesis as gout attacks in the joints. If this theory holds, we would expect an increase in CV events at the initiation of ULT, which is often prescribed following a gout attack. A sudden decrease in serum urate levels due to ULT could, theoretically, trigger more gout attacks. However, this increase in gout attacks might not be commonly observed because colchicine is frequently prescribed to prevent gout attacks. Therefore, it would be worthwhile to investigate the increase in CV events after the start of ULT in patients who have not received gout attack prophylaxis, like colchicine. Continual ULT should lead to the removal of accumulated MSU crystals in the body, thereby reducing vascular MSU crystals and, consequently, decreasing CV events. When ULT is discontinued, a sudden increase in serum urate levels or rebound hyperuricemia can occur, potentially forming free-form MSU crystals in the vasculature. I analyzed whether there is an increase in CV events during this period. The CARES trial, although designated as a randomized controlled trial, RCT, is notable for the high number of participants who discontinued the study prematurely. This unique aspect allowed for the evaluation of major adverse cardiovascular events, MACE, following the cessation of the investigational drug. Fortunately, the research protocol was designed to maintain bi-monthly check-ins via phone and mail, not only upon study completion or withdrawal but also to monitor any significant issues in ongoing participants. While not all MACE could be accounted for, this protocol allowed for more accurate identification of the reasons for drug discontinuation and subsequent events compared to a typical observational study. In the CARES trial, analyses were also performed on the modified intention to treat (MIT) population, mirroring the trial's comprehensive approach. Within this group, 448 participants experienced major adverse cardiovascular events, MACE, while on the medication, and 208 experienced MACE after discontinuation of the drug. This is a summary of the findings presented in Table 1. Notably, the group that suffered MACE post-discontinuation not only had a higher average age but also presented with elevated baseline serum urate levels. This is an important detail to underscore in our understanding of the trial outcomes. MACE occurrences while on medication are depicted by the black line, referencing the starting point of the drug regimen in a modified ITT population of 6,190 participants. Post-discontinuation MACE, marked by a red dotted line, accounts for those observed after excluding the 448 participants who experienced MACE during medication use, leaving a cohort of 5,742. As illustrated by the kilometer curves, the red dotted line indicates a sharp increase in MACE frequency within the first 6 months following drug discontinuation. Subsequently, the slope of the curve aligns with that of the black line, representing MACE occurrences during medication use. This suggests a similar rate of events post-discontinuation after the initial 6 months. However, due to the marked increase in MACE within the first 6 months after stopping the drug, the overall hazard ratio, HR, during the entire period is 2.32. In contrast, when comparing the MACE HR in the first 6 months post-discontinuation to the first 6 months after starting the medication, the HR escalates to 5.22. Acknowledging the potential sicker-stopper effect, further analysis was conducted. This entailed excluding all patients who, at any point during the study, had abnormal clinical and vital signs. The refined analysis yielded an even higher HR of 8.1 for MACE within the first 6 months post-discontinuation compared to the first 6 months on the medication. While we cannot entirely discount the sicker-stopper effect, its persistence up to 6 months is not compellingly justified. One may question the reliability of the information following drug discontinuation. Upon reviewing the follow-up duration data post-discontinuation, we note that patients who completed the trial without experiencing MACE, or those who had MACE while on medication, did not undergo further follow-up after study conclusion. This is a standard and expected practice. However, it is significant that patients who did experience MACE after discontinuing the medication were followed up for an estimated 2 months. Moreover, considering that patients who voluntarily withdrew from the study were followed up for 2 to 4 months, regardless of whether they had MACE during the medication period, this suggests that the study conducted fairly accurate follow-ups during the initial post-discontinuation phase to ascertain MACE occurrences. Furthermore, an independent committee meticulously reviewed all MACE incidents to ensure accurate classification. Additionally, within our study, there were 2,529 participants who completed the trial without experiencing a MACE and subsequently did not receive follow-up. It is conceivable that MACE could have occurred post-discontinuation in this group. We analyzed the data under the conservative assumption that these patients remained free of MACE for 6 months following drug discontinuation, which could be seen as an assumption that potentially biases against our findings. Despite this cautious approach, the analysis revealed a 6-month hazard ratio, HR, of 2.44. We conducted a detailed examination of patients who suffered CV death during the study. Red dots represent the time of death, with the cause of death noted alongside each. Blue dots indicate the onset of symptoms leading to death. All this data was provided in the CARES trial raw dataset. Upon careful inspection of the graphic representation of deaths within the first 6 months, a significant observation is that a considerable number of patients passed away immediately after the drug discontinuation date. Therefore, we considered MACE occurring up to 1 day after drug discontinuation as an event during medication use, based on the premise that the drug's effects are likely to persist until the day following cessation. Events commencing from the 2nd day post-discontinuation were categorized as occurring after medication had been stopped. This categorization informed our analysis, and the results presented thus far reflect this methodology. As indicated by the red box in the data, there are instances where symptoms emerged on day 0, the day of drug discontinuation, leading to cessation of the medication and subsequent deaths from congestive heart failure on days 15, 26, and 41. These cases are thought to represent the sick-stopper effect. However, if you look at the blue box, it illustrates patients who developed symptoms 1 to 2 months post-discontinuation and passed away shortly thereafter. The onset of symptoms leading to death 2 to 3 months after stopping the medication suggests that these cannot be attributed to the sick-stopper effect. Therefore, while some of the increase in the hazard ratio, I presented may include the six-stopper effect, it is probable that MACE beginning over 1 month after discontinuation is not predominantly due to this effect. Additionally, let us examine the cases defined as non-CV deaths within the CARES trial. However, when we examine patients who were categorized as non-cardiovascular deaths, a careful look at the red box reveals cases of cardiac arrest, as well as instances where death occurred on the same day, which are, in essence, cases of sudden death. Moreover, these results are observed throughout the subsequent period. Considering that half of sudden deaths are statistically due to cardiovascular disease, it's plausible that a certain portion of sudden deaths categorized as non-CV deaths could, in fact, be cardiovascular in nature. We conducted a multivariate analysis focusing on patients who consistently took the medication for over 1 year. The 1-year mark was chosen based on the study protocol, which stipulates that dose escalation should be completed by 6 months, allowing serum uric acid levels to stabilize. Additionally, patients who have taken the medication for over a year are less likely to discontinue due to adverse effects, hence they represent a group more likely to maintain medication adherence. This approach was designed to specifically investigate the occurrence of MACE in the context of medication discontinuation after a sustained period of use. Let's consider the rate at which uric acid levels increase following the discontinuation of the medication. Conducting such research today would be challenging due to ethical considerations. However, a study from 50 years ago indicates that rebound hyperuricemia can occur as quickly as 1 week after cessation of the drug. In our research, by using the serum uric acid levels during medication as a reference, we observed that rebound hyperuricemia occurred at the 2-week mark following drug discontinuation, as shown in the graph. Blood tests were performed at various points after discontinuation in a subset of patients, which led us to consider the potential limitations of performing a multivariate analysis solely based on these sporadic uric acid levels. After much consideration, and based on the observation that post-discontinuation uric acid levels often return to what they were before medication started for many patients, we defined the change from baseline uric acid levels as an indicator of rebound hyperuricemia. This change from baseline uric acid was then used as a variable in our multivariate analysis of post-discontinuation MACE. The results showed that for every unit increase in change from baseline uric acid, the hazard ratio, HR, was 1.14. Intriguingly, when this same variable was applied to the multivariate analysis of MACE during medication use, the HR was 0.99. This demonstrates a shift in the association of the same variable with MACE depending on whether it was during medication use or after discontinuation within the same patient group. This concludes the discussion on the reanalysis of the CARES trial. Now, let's turn our attention to the FAST trial, which closely resembles the CARES trial but has 2 important differences that I believe are worth noting. Unlike the CARES trial, only about 1/3 of participants in the FAST trial had a history of cardiovascular disease. Additionally, the FAST trial was conducted in Europe, where, due to the public health system, the rate of discontinuation was lower compared to the CARES trial. As you can see from the results, the Kaplan-Meier curve for Febuxostat is slightly lower compared to Allopurinol, which is consistent with the all-cause death rates. Although these differences are not statistically significant, they present a contrast to the findings of the CARES trial. While one could argue that non-significant results imply no real difference, it is nonetheless notable that in the FAST trial, Febuxostat showed a marginally better outcome, whereas in the CARES trial, it was associated with a worse prognosis. Additionally, as previously shown, the FAST trial had a follow-up loss rate of approximately 5%, in contrast to the 50% in the CARES trial. We believe that this significant difference in follow-up loss may have contributed to the differing results between the 2 trials. Hence, I utilized the duration of medication use and the timing of mortality, as previously shown, to conduct an analysis similar to the CARES trial. This analysis was based solely on tables 2 and 4, not on the raw data from the FAST trial, which unfortunately I did not have access to. While I would have liked to verify whether rebound hyperuricemia contributes to MACE using the FAST trial data, I was unable to obtain permission from the team that conducted the study. I would be extremely grateful if they could undertake research using the same methodology as ours. Given the well-established public health system, I surmise that the FAST trial's raw data might contain more comprehensive information on outcomes and uric acid levels after medication discontinuation. Nevertheless, our comparative analysis of mortality during medication use and after discontinuation showed that the risk of death increased approximately 5-fold for allopurinol and 10-fold for febuxostat post-discontinuation. Additionally, cardiovascular deaths also showed an increased risk of mortality after discontinuation of febuxostat, which is consistent with our observations. As you are aware, the CARES and FAST trials have shown markedly different results. However, in both studies, there is a consistent observation that mortality post-discontinuation is more frequent in the febuxostat-treated groups compared to during medication use. My assertion could be considered bold, and to substantiate it, it would be crucial to examine outcomes for patients who have stopped taking allopurinol or febuxostat, either at the proper conclusion of the study or due to voluntary discontinuation, across all relevant research. While a reanalysis of the FAST trial would be ideal, it is necessary to seek verification from other studies as well. To summarize, a reanalysis of the CARES trial data revealed a significant increase in MACE during the first 6 months following discontinuation of the medication, with rates subsequently stabilizing to the same level as during medication use. A key point of my presentation today is the association between post-discontinuation MACE and fluctuations in uric acid levels. It's well known that many patients discontinue urate-lowering therapy (ULT) when gout flare-ups decrease, traditionally viewing gout as a joint-specific disease. However, stopping ULT may potentially precipitate cardiovascular events. While I can't show you the data since it's under submission for journal publication, I have found evidence suggesting that maintaining ULT can be beneficial in slowing CKD progression and reducing MACE. Considering this, it's increasingly likely that gout is not just a joint disease but a systemic one, and consistent ULT maintenance could be as crucial as medication for hypertension or diabetes. Future research may need to explore starting ULT at low doses to gradually reduce uric acid levels and the long-term low-dose maintenance of colchicine. Thank you for your attention. Should you have any further questions, please do not hesitate to contact me via email.